an easy subject, and what I'm going to be talking about is I've made it as simple as possible. A lot of it is what we have learned during our medical school, but this kind of translational study and research is not easy. So for many people to understand, I may have to go back to the basic and explain what we have found is what the nature, is all about. And it's so complex. As we are going through this, we'll understand that it's not easy to beat what nature has created. So why did we start the yellow series? The series was started just because when we see patients, they ask a simple question. Doc, I do everything right. I still have new lesions despite what we call as the good medical therapy that they are on. So this question comes in two kinds. One is if they have obstructive lesions or non-obstructive lesions. So we are going to handle that one by one. So how to prevent atherosclerosis progression, or can we induce this plaque to regress? And that was the main question behind our yellow family regression study. The reason yellow is coming from reduction in yellow plaque by intensive lipid lowering therapy. So if you see here, we started way back 2009. So 2010-12 to 2024 up to yellow 3. So a lot of things have changed. Used to be statin when we first started, then became intensive statin therapy. Lot of imaging. Initially used to be only ultrasound or so. But then way back in 2010, there was introduction of NIRS. Then intensive statin therapy. That's how we changed to yellow 2. Coming to yellow 3 about 2015, more aggressive lipid lowering treatment was started by using PCSK9. So let's go through this one by one. So if you go to the concept, the same question of the patient that I have a blockage, how can we take care of it? So Ivers had already demonstrated that, in non-obstructive lesions, that statin therapy helps to regress the plaque. Can it be done in obstructive lesion? Because that's the question. So that is why we started that. Can we give statin therapy and see what happens inside the plaque? To understand what happens inside the plaque, the only way we could understand is by doing imaging. And we had two kinds of imaging, which was IVUS as well as what I'm going to show you was NIRS and how it works. So essentially understanding how the lipid changes inside the plaque. You can see it? Yes. Okay. How it changes inside the plaque. Thing has changed here. Okay. So this was a NIRS, which was initially, actually Pedro Moreno was part of starting this, I would say, NIRS. Can you come here? Everything, we can't see anything here.
Oh.
Yeah.
Oh, okay. That's dramatic.
All the slides were gone.
This
Just talking with my... So what part where you understand compared to histology. So if you see in histology, this is how normal vessel look. This is how the plaque with the lipid looks, and the chemogram will show you yellow. So that is why this imaging was essential for this. Oh, again, it did the same thing. You know what? No, I can. I think I was pressing the wrong. That's fine. Good. And we use that, and several studies subsequently has shown that there is a number to understand in the NIRS. The number 0 means there is no lipid. Up to 1,000 means very high lipid. That is why the number is important. And we did our yellow trial based on these numbers. So going back to the yellow one was that obstructive lesion. Patients, we got to make sure they're obstructive. The only way we could have understood that is by doing a physiology. So patients with obstructive lesion, we did FFR first. And then once we know that it's obstructive, that FFR had to be less than 0.8, we randomized those patients to standard therapy or aggressive, because at that time, new agent rosuvastatin came into the market and everybody was like, you got to be on rosuvastatin 40 milligrams or no. So the question is, do you need to be on that high dose to really regress the plaque? So like we are talking, we do not know what the nature does, what happens, to the entire plaque. So we need to understand what happens. So we did it between 6 to 8 weeks. And when the patients came back, we repeated the imaging. And what did we find in this? I think you have to come out. It just keeps changing. No more present to be. It just keeps changing no matter what we press. So what did we find was that, of course, the total cholesterol changed, decreased significantly in aggressive arm, LDL changed, and if you see here, which everyone knows when you're on statin, C-reactive protein also, which shows that there's inflammation decreases. What we expected, but what did not happen is that FFR did not change, which means we thought FFR is, if it is abnormal, when FFR increases, which means that so-called the plaque is regressing and your FFR is increasing. And now we can answer the question, maybe you go on therapy, you may not need anything done to that obstructive lesion. We could not one, it is a small number of patients. Two, we did it with a smaller period. So that could have been the reason. But of course, what did the NIRS show? That there was a reduction in the yellow plaque. So yes, we can see some changes in the plaque. So we were able to make that decision. This is a case example, what you see here, that a patient, this is what you see, an FFR, which is 0.74, which means it is significant obstructive plaque. That is lipid in the plaque. And when they came back for follow-up, we see some change in FFR. Okay, it's not normal, but some change in FFR, but change in the LCBI, which is saying that yes, the plaque is changing. Should we have waited longer? Could have been. But what was interesting, what we found that if there was no change in FFR, we did not see any change in LCBI. And also what we found is about between 25 to 30% of the patient never had any lipid, means they were a fibrotic late stage plaque. So those kind of patients could not respond to therapy. If there was any change in FFR, those patients were patients who had big LCBI or they had to have lipid inside them. So our sub-studies will be discussed later and we will know why. That means what we are learning, that you want to make changes. We are going back to the question of that patient. You need lipid in the plaque. Then you can give the therapy to this patient. So yellow one, what did we see? That yes, regression can be achieved in obstructive lesion. You need aggressive statin therapy. FFR improves, but only in lipid-rich plaque and when there is a high LCBI reduction. So what did we learn? If you want to go and understand how plaque can change, that enrollment has to be based on lipid, that you need lipid in the plaque. If you don't have lipid, do not take a fibrotic plaque and they give therapy and say, okay, can things change? By then, like I mentioned, obstructive OCT, which is optical coherence tomography, came into equation, and that was giving understanding of the plaque better. What is a fibrous cap? And I will tell you that we understood, okay, plaque changes. So how does the plaque change? Exactly what happens in the body. And that is what is called as HDL functionality. To go there, I have to go back to a little bit of physiology, biochemistry to understand what happens in the body. So this is just an example why OCT was important, because you'll see what is, you'll understand. It is like, what the cap looks like, lipid arc looks like. But more important, you can also see some kind of inflammation if you're using OCT, because you can see macrophages. Why I'm showing all this is what we saw as we are doing the study. So going back, deep dive into physiology and biochemistry, very important is as soon as we eat fatty food, the fat as well as cholesterol gets into the intestinal cells. From there, we have B48. Now, what happens to the fat? It is hydrophobic, not hydrophilic, does not get into the blood easily. So you need some kind of a protein attached to it. So it's called as a lipoprotein. So there are various lipoproteins in the body. So this is the first protein that comes out. That's called as chylomicron. Okay. That gets into the blood. So it goes through the circulation, extrahepatic tissue, and this is where we are interested, is to see what happens in the blood vessel, heart, brain. So a lot of this, fat and triglyceride is removed. It is called as chylomicron remnant, gets into the liver. So if you see this, it's called as extrahepatic. Okay. Then there is what is called as intrahepatic. Lot of the cholesterol is also being formed in the liver. Then little bit of triglyceride comes out as called as VLDL. Then again it circulates, gives out more of the triglyceride fat out. It becomes intermediate. When the triglyceride completely disappears, it becomes LDL. So very important, LDL is only cholesterol. That is why when the patients come to see you, you are only interested in the LDL. This LDL, this receptor is so important. LDL receptor gets taken into the LDL receptor, and bile is formed. From there, the bile gets into the intestine, and this circulation continues. So this is just the tip of the iceberg. I'm explaining. The nature is so complex, and remember the 7 colors of the rainbow. Like that, you have 7 lipoprotein. Why you need to know? All these lipoproteins are bad, and they are associated with what is called as ApoB, which is bad. The good cholesterol, which is HDL, which is right here, is ApoE, which is associated with that. So what happens is that it is very important. That is a good homeostasis between HDL and other lipoproteins that I just mentioned. HDL is the only one that is good. The rest are all pro-inflammatory. Everybody knows it. So if you are healthy, everything is good. The homeostasis is maintained. You have a healthy vessel wall, beautiful intima, nothing wrong. What happens? Any of this goes haywire, which often is right here. That's when you start forming what is called as a atherosclerotic plaque. And that's what we do not want. Another important part of this whole mechanism is what is called as macrophages. So you have simple cells called monocyte. They get their signals come to the monocyte, they change. So macrophage, M1, M2, and you'll know a lot of this in the yellow study. So M1 is pro-inflammatory, is bad, causes tissue damage. M2 is very good. It is causes anti-inflammatory. Phagocytosis goes and takes out all the cholesterol, and you want M2 in your body. And what is important for M2 to function is mitochondria. So M2 works with what is called as a mitochondria, and mitochondria is the powerhouse, is the essence of your life. So if every cell has mitochondria except RBC, maybe platelets. So it has its own DNA and has a gene expression. You take care. Every cell of the body requires mitochondria. So today we are going to learn a new concept, what is called as healthy mitochondria. That's the new concept, and we need mitochondria. For mitochondria to function, you need oxygen as well as what is called as aerobic mechanism where oxygen is required. Phosphorylation gives lot of ATPs. You have a healthy mitochondria, lot of ATPs, lot of energy. Just remember that. And that's the baseline. Another concept that we have to know and what we understood is, okay, you don't have a healthy intima. What happens when you get abnormal intima? This is what we see when our patient comes to us. This is healthy, nothing wrong. Lot of LDL, that LDL that's in the lumen gets into the vessel wall, and what happens? There's a whatever the signal that goes to macrophage. So remember I said there's macrophage M1. So M1 gets activated, which is a bad macrophage, takes all the LDL. That is what's called as a foam cell. It keeps eating and it dies. And we know what is apoptosis is programmed cell death, that it will keep dying. There are healthy macrophages, which is M2, which has a lot of energy, will try to go and eat that. That's called as atherosclerosis. You'll hear a lot of this later on. One thing that we did not, which I wanted to mention and which is important as a part of yellow 2 was, how does all this plaque come out? There's an important particle, the high density, which is associated with ApoA. The others were ApoB, which is all bad, but ApoA is good. So what does HDL do? it takes out that so-called cholesterol from the macrophage back here and then gets onto the liver. So you need HDL, the good particle, to get rid of the plaque. So HDL is very important. So going back to that is called as reverse cholesterol. Remember, the cholesterol came from the liver to the tissue. Now from the tissue, it's going back. So it is called as reverse cholesterol transport. For that to function within the macrophage, there are certain receptors there, which is called as ABCA1. They call it briefly as ABACA. You could have heard a lot of that. Important enzymes, LCAT, CETP, all these are important and they should be functioning for LDL to take the cholesterol and take it back to the liver, from the liver bile into the intestine. So you can understand how complex this mechanism is. And we wanted to understand, does this mechanism work in these patients so that we understand exactly what happens. We all know where statin works, because another important part is you have to understand, go back to your biochemistry from glucose to cholesterol, right? There are multiple steps. Statin works at HMG-CoA reductase, right? And also what it does, that it increases the PCSK9 level, which is another protein responsible, works on the LDL receptor, blocks the LDL receptor. That's how it works, okay? So why I am showing this is two enzymes that we found that was important, and their genes one is SQLE DHCR24. These two enzymes are the final pathway for cholesterol mechanism. And you see ABCA receptor in the liver also. So you see this receptor in multiple places. So knowing all this, let's go back what we did in yellow 2. So we have to understand what happens in the plaque, which is intravascular imaging, which we used. Okay, so we enter to understand what happens to the fibrous cap, what happens to the plaque, the lipid inside. So whatever I've explained to you so far can only happen through the DNA giving the right signals. So you have a DNA, the transcription becomes to mRNA, which is called as translation. So this small little mRNA is a one goes and tells, okay, you do this job, you do that job, or don't do this job or that job. So that's how it happens. We haven't come to this part yet. So we just said, why don't we go? One, we have to understand, does this mechanism work, which is cholesterol efflux? That's how the plaque regresses. And do we know that if this kind of transcription and translation happens in these patients? So the hypothesis was simple. HDL functionality is that how the plaque regresses. Again, we took obstructive lesions, and more important is understand cholesterol efflux. Does cholesterol efflux work in these patients? And is that related to what is called as the change in the PBMC transcriptome? So we did, patients came, went through what is imaging. This time, we already studied. You have to give high dose statins. We gave high dose statins for 8 to 12 weeks. When they came back, imaging was done. But more important is we did cholesterol efflux on this patient at baseline, as well as we used peripheral blood mono. That's the only way you'll understand the genetic profile of any patient. But the testing we used was microarray, which is old technique. So these are very simple. Cholesterol, we know, decreased. Like I explained, the bad, B for bad, ApoB went down. A is for good. Everybody should be type A. So ApoA went up, which is good, which means it's associated with HDL. And more important is cholesterol efflux. When you give statin, efflux improved in this patient. So which is all, going with what we learned, and understood that the lipid length decreased. And I showed you on OCT, we can see macrophage length, right? Tiny macrophages, and that macrophages also decreased in these patients. Everything is falling in place, and everything is going as what the nature wants us to do. Other important thing that we found, which is that cholesterol efflux capacity correlated with the fibrous cap thickness. which is also again making sense. Better cholesterol efflux, which means lipid is going out as a part of healing. Smooth muscle cells come and cover the cap. So fibrous cap improved. And your CRP, which everybody knows is inflammation, went down, means your fibrous cap got better. So now, what was the change in the gene in these patients? Yes, it improved with their imaging profiling, the changes in the gene. You remember I mentioned SQLE, DHCR, which are all associated with the terminal, formation of cholesterol in that cholesterol mechanism pathway. They were there. Remember ABCA1? So ABCA1 is a receptor. We saw changes in that. Essentially, changes in cholesterol mechanism and changes in your receptor, which means your HDL functionality improved. So we were able to see what we wanted. This was a central figure, and this is just one of the picture that we are showing that obstructive lesion. This is what the cap was. With statin, cap improved, and of course, lipid went down. What we also found is that can we do machine learning and understanding? Because we have our patient group was very small. First time we coined what is called as a non-responders to statin. At least half of the patients were non-responders. Why were they non-responders? Because we found that they had the difference means that the responders had some important 18 genes, which is here compared to non-responders, which was in the red. And what was this gene? They were responsible for immune cell function, cholesterol mechanism, protein modification. Again, same thing that we found the pathway. So what did we learn from yellow 2? There was improvement on the cholesterol efflux capacity, and there was still a group of patients who did not respond to statin therapy. Their LDL changes, but on imaging, there was non-responder. So what do you want to do? Maybe become aggressive lipid lowering, or do you need longer duration? And other thing is you want to change the enrollment, that you want lipid arc as well as fibrous cap based on the OCT. So by then, 2015, there was addition of what is called as a PCSK9 inhibitor. So going back, liver is such an important organ. Going back, how PCSK9, which I already mentioned earlier, it goes, it inhibits this receptor. This receptor actually takes LDL into the so if you inhibit that, more of the receptor is available. LDL will go in the liver, and that kind of homeostasis will continue. So we decided, let's go aggressive therapy and add PCSK9. So if you think about PCSK9, most of the studies during this time was in ACS patient. We were the first one to say, let's use PCSK9 and do our study in stable patients. What we wanted is same thing, understand what happens to the plaque, but now we will go and do a different kind of a gene expression using a different kind of array with a gene expression, understand what happens. So primary endpoint was change in fibrous cap thickness and LCBI, but see what happens to the gene expression. So what happens, you see here, enrollment was based on OCT, make sure there is lipid-rich plaque and fibrous cap had to be thin. Then we gave statin plus evolocumab, and we had to increase it for 26 weeks. And after that, we did PBMC transcriptome using what is called as a bulk RNA sequencing. So what's the meaning of bulk RNA sequencing? You take the blood, there's so many cells, you take all the cells, they clump together, and you check what happens in their genetic profiling compared to single cell. That's a lot of work. Means you go individually, cell by cell, you understand what happens into the genetic marking of this single cell. That will be the future. So simple, lot of changes with your total cholesterol and LDL. And we know PCSK9 does not do a lot when it comes to HCRP. So that's what you see there. Fibrous cap improved, expected. And LCBI, what you see here, definitely changed. So one, aggressive statin, and two, longer period. So maybe that's what you need. We don't know yet. What else we found? That Fibrous cap improved in about 80% of the patient. We call them responders. And change in LCBI about 76% of the patient. So there was what is called as, we coined a term which is called as melting butter. I hope you see all the butter is gone. Then we saw a group of people, non-responders. That means they never, the lipid never changed, the cap never changed. You see here, cap was 50, remained 50, LCBI remained the same. But what happens when they come to the clinic? What do we check? LDL. And what do we tell the patient? Hey, you're fine, no problem. Okay, look at the LDL, 78 and 7. So these biochemical markers do not tell us what is exactly happening in the body. So we would say about 20-25% non-responders exist. So how do we understand who is non-responders? How do we understand? So this was the paper just came out 2 months ago, and the melting butter sign is coined. It's all over now. Hashtag melting butter sign is out. First question was, is the change in LDL, change in total cholesterol the same between responder and non-responder? Yes, they did respond biochemically. Let's see what happened inside their body. Outside, biochemically, maybe they were different, but what happened inside? So, like I mentioned, it was a bulk RNA sequencing. And so what we found was 922 upregulated. All this upregulated is red, 571 downregulated genes. So what was important? So what happens is when you do these genes, you need to understand, you cannot sit and count each gene to see what happens. You got to put them in a special program, which is called as a ingenuity pathway analysis, and it's called as a canonical pathway enrich. So they tell you multiple genes are associated with various pathways that we have described. Remember, we have gone through so many pathways that are important in our body. Orange is upregulation. So what was upregulated? ATP synthesis, which is again mitochondrial function, mitochondrial translation, protein synthesis. All this is part of the cell function. All this is upregulated, trying to tell us your mitochondria becomes healthy, mitochondria becomes strong. When that happens, then your plaque changes. There was downregulation of mitochondrial dysfunction and cell surface interaction, but more important is your immune functions, everything went down, which is trying to tell us that they probably, their immune function was better than this. So what happens in the responders? Again, we go back to the simple question that mitochondrial function improved, cell response to stress improved, protein synthesis improved. You need a healthy mitochondria. So non-responders, mitochondrial function did not change, was the same. So going back, that neutrophil degranulation increased and inflammatory pathways remained in this patient. Question is it the mitochondria that causes inflammation, or is the inflammation that is causing mitochondria to dysfunction? We're still getting into that. We don't have an answer, but I think we know that it's other way around. So we know everybody goes IL-6, TGF-beta, all these are associated with the inflammation. So what we also found that the downregulation of these genes, inflammation going down in the patients who have responded. Going back to the patient's question, right? Would he respond or non-respond? How do we answer that question? We still don't have an answer. The question now comes to, we have baseline transcriptomic signature of this patient that we know this is the kind of, RNA molecules they have. So with the machine learning, we were able to predict which patient will respond and whose fibrous cap will improve. And those 38 baseline genes are here, and their AOC curve was significant. And what are those important baseline genes associated with inflammation, improved mitochondrial function, and wound healing? Same thing, we found some transcriptome for LCBI reduction. Again, mitochondrial function is coming. Every time is mitochondrial function. Now question is, can you overlap? Can you see who had both fibrous cap improvement as well as LCBI response? Most of them you see here, ILR1, which is upregulation of M2 macrophage, which is a good macrophage who has a good mitochondria. MMP9, which was also there, and more important, C4 comes everywhere. C4 is an enzyme that is on the cell surface that tells mitochondria that you should function better. Going back to mitochondria. So what we are finding from yellow 3 is that there is a subset of patients that did not respond, and association of plaque stabilization for improvement in mitochondrial function. So what we found is that you need a mitochondria that is functioning, and this is something that we are focusing moving forward. So this animation is nowhere, came way before ChatGPT and the cloud came into existence, was created by Andrew and Yulia right here. So all that I've discussed is here. Monocytes come, you see that they go in, they sweep inside, they change into macrophage. You see that. So monocyte addition increases, lipid takes over, foam cells. So what happens into the macrophage? Mitochondria that you are talking. Mitochondria starts overworking. It gives a byproduct, and that's called as reactive oxygen species. You do not want that. It is like the rust on the iron. You do not want that. When that goes up, your mitochondrial dysfunction starts. That's how you start having apoptosis. As apoptosis increases, what happens is there's lipid and a lot of other things. Accumulation happens. The plaque gets bigger, and the fibrous cap becomes thinner. When you go evolocumab, see what happens to monocyte. We saw that the cell keeps disappearing. So everything reverses. And your smooth muscle contractility changes, fibrous cap improves right there. So this is what we found, okay, after we give PCSK9. So you see that fibrous cap improves, plaque starts going down. So lot of research has happened, you see that. But what we first time we are showing is that genotype changes that we found was seen in the phenotype, which was decrease in macrophages and lipid-rich necrotic core change. So first, we are the one to show that what changed that. Going back to what macrophage is all about, a lot of this is already discussed. We said that you want M2 macrophage, which is healthy, that works through oxidative phosphorylation, okay? That helps cholesterol efflux, that helps phagocytosis and atherosclerosis. It's been already published and proved that healthy mitochondria is very important for cholesterol efflux and work as anti-inflammatory to work in atherosclerosis and phagocytosis. So for plaque changes, you need healthy mitochondria. When you're going out of this room, just one thing, healthy mitochondria. When mitochondrial dysfunction starts, you see that obesity, smoking, hypertension, diabetes, there's increased ROS production. That means dysfunctional mitochondria. Impaired mitochondrial electron transport chain gives rise to what we see in our current population. Okay, so we cannot have abnormal or unhealthy mitochondria. So melt the butter, get a healthy mitochondria. The question is, how do we do it, right? How do we get healthy mitochondria? Not easy. No drugs. Okay, this is all under trial. Nothing has been proven. Can we do it with diet, intervention of mitochondrial dysfunction? Yes, several publications showing you need healthy mitochondria like here, which can produce lot of energy, lot of ATP. Oxidative phosphorylation means eat healthy. Okay, so it has been shown over and over again. So when you eat this junk food, you get unhealthy mitochondria. So then the question comes is, look at our friends, everybody eating behind my back, all right? Or you want to just remain eating healthy food. Then comes, okay, eat healthy. People keep saying exercise, exercise, exercise. What is the science behind it? So publication came out in 2024 that exercise improves mitochondrial homeostasis and mitochondrial function, maintain mitochondrial protein. This is exactly what I was describing and exactly what people are working on. That when you exercise, your mitochondria becomes healthy. So these are the some simple things we can do to keep healthy mitochondria. Other thing is exercise duration important? So this is the publication that just came out in BMJ in 2026. Yes, exercise is important, decreases all-cause mortality. And you see that happening just about right here, which you need about 15 metabolic equivalent of task. Not easy to get that. You just, if you say a walking, you barely reach there. You have to do some kind of high intensity workout and various kind of workout to say exercise is important. And first time they're showing it is associated with decrease in mortality. So overall, this data support the notion that long-term engagement in multiple type of physical activity may help extend lifespan. We are just putting together. Exercise improves mitochondria, and that healthy mitochondria will be responsible for probably increasing your lifespan. That is why exercise physical activity is part of ESC guidelines, who actually increased. Initially used to be 75 to 150 minutes. Now they made it to 150 to 300 minutes per week of aerobic exercise of moderate intensity. There's a big line of what is moderate, what is high, or 75 to 150 of high intensity. Same thing as made it to AHA. So we have learned that PMC, that mitochondrial function is important. What we did not know, study so far, and what we want to do future is the proteomics and metabolomics. That is not RNA. RNA goes further down to give protein and metabolomics so that we can identify biomarkers, so we can answer the patient's question. You come to the clinic, they ask that question, you have a biomarker to say what is the treatment and would that person respond to that treatment or no. So this is what we want to do in yellow 4, that we'll be doing transcriptomic, metabolomics, proteomics, and mitochondrial function, because right now it's all about healthy mitochondria. And we're going to randomize because there's a standard of care. Even the guidelines is saying go statin and ezetimibe before you try to give to PCSK9 of any form. So take home message from yellow 1, yellow 2, yellow 3. Yellow 1, intensive statin for reducing lipid core. Yellow 2, you need improved cholesterol efflux, okay? And there is a transcriptomic signature for statin responders. Yellow 3, that we found despite high, statin, I would say lipid reduction, there is a group of people who are called as non-responders. And that is what we need to work on, which is the next frontier. That is to understand mitochondria and probably what is called as a personalized prediction of response. And that can only happen in serious ways. One of the future direction is, it's not easy to do a drug discovery, especially if you want to have a drug for mitochondria. But now you have AI, the same thing instead of 15 years, maybe we could do it in a couple of years. And that is our goal. And the second thing is, when patient comes to see you, can you have what is called as a personalized treatment for CAD? For that, instead of doing intravascular imaging, we could do non-invasive imaging, blood test. But more important is take the whole genetics and other risk factors into do an AI model and create what is called as a personalized response to that particular patient. So we are going back to the original question of the patient of what can I do? So all this that I've described is on the website called as yellowtrials.com. And these are the various important publications that have come out of Yellow and sub-studies. Some of them will be discussed after me. This was not easy. Lot of people who are already here have helped me to do these studies, which is we have Dr. Narula, Dr. Moreno, Dr. Roxana Meran, and of course, Valentin Fuster has been heavily involved, understanding and helping me with all that is there. And finally, nothing would have happened without Dr. Samin Sharma. I think I went 5 minutes about. And thank you for KTT. There's a new term we have, kinetic tank. which was myself, but more important, a couple of people that I need to thank also who helped me was Yulia. Stand up, Yulia. Who joined me about 13 years ago and has been, very vested to get this thing. And more important, one person that left earlier. You see that our research coordinators go, consent, do everything for the patients, do a lot of things. They keep changing, but we have a robust team that is right here. Thank you. So I'll be introducing the second person that will be talking, who is Dr. Pedro Moreno. So we will have question answers at the end. So Pedro Moreno, please, who has been a colleague of mine, who right now is a professor of cardiology, but director of quality services for the Mount Sinai Health System. But he's a director for a fellowship program at Brooklyn Hospital. Pedro Moreno, but how do I call him? The plaque master. His interest is imaging in plaque.
Well, it's been an incredible journey for Dr. Kinney and associates to bring in 45 minutes 17 years of work. And what really means these yellow studies is how can we prove in humans on the plaque what is being published or what is experimental in the translational medicine. This is an incredible and really, really important field. Now, what is plaque regression? It's not that complex. It's restoration of health. Disease, we lose health. We recover health because we improve the mechanisms that maintains health. Which are those mechanisms? We have to get rid of the lipid, resolve inflammation. We have to increase the exit of macrophages from the plaque. That term is called atherosclerosis. And most importantly, we have to protect the plaque. We have to increase collagen deposition. We already discussed this. There are two pathways of restoration of health in atherosclerosis. One is to get rid of the lipid, and the second one is to increase the fibrous cap. So we're going to focus on those two aspects of health. Very good. So I'm going to create a framework for you guys to remember, to make it simple. How can we restore health specifically on the lipid component? And this is it. We reduce lipid, we resolve inflammation. At that moment, the genes change, the expression of those genes change. We have this transcriptional reprogramming. And most importantly, we reestablish the monocyte efferocytosis. How did we do it? Or how Dr. Kinney with the group did it? Basically reducing lipid. That was everything. Everything was reduce the LDL, improve the HDL, and you really get a 60 to 57% reduction, and it's about the same what you get in lipid core exit from the plaque. This is amazing. Now, the second component is the resolution of inflammation. And this goes to what is called disease, is the failure of resolution of inflammation. Failure of resolution of angiogenesis, cancer, atherosclerosis is angiogenic derived diseases. If it's failure for what is failure? When the stimuli is not there anymore, or with persistent stimuli, the body cannot resolve. So this is the enemy of health. Resolution is health. Let's talk about that. Well, what is resolution of inflammation? Has to be decrease of the entry of these inflammatory cells into the plaque and increase of the egress of these inflammatory cells from the plaque. So decrease the input and increase the exit. What really happens? This is work done years ago from the work of Peter Levy and Farouk, is the opposite. the atherosclerotic plaque in the experimental animals has more increase of monocytes. And to show the egress, the efferocytosis, the Dan Fisher's model of transplant of atherosclerosis from the ApoE knockout mouse, a diseased animal, you extract about a centimeter of the aorta, and you transplant that plaque into a healthy animal, what is called a wild type, doesn't have the ApoE works, or the diseased animal, which is the ApoE knockout. And you can see here that the diseased animal triplicates the size of the plaque in 2 weeks. But the wild animal who has the mechanisms of health destroy the plaque in 2 weeks. Very important. So efferocytosis, the egress of macrophages, is related to this type of macrophage that we already discussed, which is the M2 macrophage. Multiple macrophages has been described, the efferocytosis of the red blood cell, which, you know, the work of many friends of us have done that, the hemoglobin, haptoglobin, CD163, the heme macrophage, all of those. But it's interesting that Dr. Tabas created this new hypothesis, which has been working now, which is no, we don't have M1 and M2 and M4 and M-heme and haptoglobin. No, it's the same macrophage. It is the plasticity of macrophage. How does it work? Well, when you need inflammation, you have to promote inflammation to resolve the aggressiveness. And when you have to turn off inflammation, then you become what we call the phenotype of the M2 and the M1. So it is the balance between the pro-inflammatory and the pro-resolving mediators what generates the real macrophage phenotype. That's unbelievable. And it makes sense because this is your own health. Okay, so we have discussed what is called macrophage efferocytosis, what is resolution of inflammation. We're going to go now into the transcriptional reprogramming that Kinney already elegantly did. And what is this? Well, we have to reverse cholesterol transport and increase the efflux of cholesterol. She already showed this slide, but what happened? Well, the cholesterol goes into the plaque, oxidized minimally oxidized LDL. The CD36 receptor of macrophage introduced the cholesterol inside the cell. The esterification of cholesterol release free cholesterol inside the cell. So the free cholesterol has to go out. How does it go out? With the cassettes. The cassettes are the ABCA1, the ABCG1, and the SRB1. And this free cholesterol goes to the unloaded ApoA1 or pre-beta, pre-HDL, and it goes with the reverse cholesterol transport. So is this the cholesterol efflux capacity? Summarize this complexity thing. How can your macrophage can perform the work, which is give the free cholesterol to the HDL? That's the capacity of the macrophage. It's the healthy macrophage. However, and we already saw that in only 8 to 12 weeks, we can change the phenotype. We can do this reprogramming, specifically on the cassettes that will increase the cholesterol ester capacity. Okay, so Kinney said, yeah, we took the monocytes, the peripheral blood monocytes of these people. We did it here. We label the H cholesterol with the hydrolyzation, is H cholesterol. We activate with the cyclic GMP, the ABC1, and then we measure. And she presented the data in the peripheral blood monocytes, resolution of inflammation, and increase of the efferocytosis with cholesterol extra capacity. Finally, we need to reestablish the monocyte efferocytosis. I show you that. These are the two genes that are responsible for promoting inflammation and resolution of macrophage phenotype, supporting the reprogramming during efferocytosis, and those genes were identified in our study in the yellow 3. Very important. The data is in the supplement. The holy grail of the future of our work is in the supplement. The paper is just a summary, but the supplement is a treasure that we have at hand. Now, how these macrophages, which are aerobic cells, leaves the atherosclerotic plaque? Well, it does it through the neovessels. And how do you know that, Dr. Moreno? We know that because we saw it. We stain the endothelial cells of microvessels with CD31 attached to a blue chromogen, and we stain the macrophage with a CD68 antibody, which is the lysosome of the macrophage, with a red chromogen. And we saw in human atherosclerotic plaques that the macrophages are exiting the plaque through the microvessels. Resolution of inflammation, resolution of angiogenesis. When there's no more macrophages, there's no more lipid, then the angiogenesis resolves. And we have restoration of health. Okay, we talk about the lipid, now we talk about the fibrous cap. And I'm going to do the framework a little faster so we finish this. But the framework is important. We have to phenotyping switch the population of the smooth muscle cell. Instead of being contractile, has to be a secretion smooth muscle cell that will produce the collagen through the TGF-beta. Suppression of collagen degradation, fundamental. If we do collagen degradation, we rupture the plaque. Macrophage switching towards the M2 preparative phenotype and the promoting of the matrix deposition. One example for each of these, and we will be done. The switching will be increase the migration of the smooth muscle cell from the media to the intima and upregulate collagen 1 and collagen 3 synthesis. We learn a lot about collagen 3 with wrist stenosis. We learn a lot about collagen 3 evaluating rupture plaques in humans that are already healing through collagen 3, 2, 3, the healed plaque. And we restore the smooth muscle cell survival. We cannot have apoptosis. Then the thin fibrous cap will become a thick fibrous cap. Again, which gene was this? The myosin light chain 9, which was upregulated, and it is the one that is repopulated in vascular smooth muscle cells, and Dr. Kinney did it. We have it in the supplement. There's the gene. What about thickening of the fibrous cap with the suppression of the collagen? This gene called the CEMIP is very important in the degradation of the glycosaminoglycans of the extracellular matrix. The glycosaminoglycans are the goalkeepers of the subendothelium. It gives the minimally oxidized, they keep it, no going. When you failure to do these extracellular matrix proteins, you have trouble. And yes, again, this gene is there in the supplement. The thickening of the fibrous cap with the macrophage switching, we already talked about this. The ALOX 12 is the one that makes you the phenotype for efferocytosis, and it's over there. And finally, the increase of, we discussed this, but I want to give you one final thought. One final thought. It's going to be mostly an open question. We already discussed this. The patient comes, you got LDL is 7, you think is great, and the guy is a non-responder. This is deceiving, as a term I use. It's a deceiving non-responder. And are there the smaller or the larger? Well, look at this. The best thing we have, the PCSK9 inhibitors. 2% reduction, 14%, 12% out of the 14 non-responders. It's so depressing. So what can we do after GDMP? What can we offer to the non-responders? And I said it's going to open questions specifically for people in the front row here. What is the response to therapy? Responder, we're very happy. How can we tell if the patient is a responder or not? And what can we offer? Maybe with the ultra photon counting, blah, blah, blah. Dr. Narul is an expert on that. But what can we do? Let's assume we recognize the guy has 3 vessels, is doing the best he can, the LDL is 7, but the photon counter says that the fibroscop is and the Housing units are 30. Question, answer. Should we help him to create a neofibroscop? That's a question for Dr. Stone. Thank you so much.
Excellent presentation, Dr. Moreno. Our next speaker would be Prithvi. Prithvi joined for this year. He did research fellowship with us, but he has done a lot of research in India as well as in Europe. And one of his interests was imaging. And so we'll work on that. And he joined us in July. But within 3 months, he was able to do a lot of work, submitted a lot of his work already and presented in ACC 26. So he's going to talk on the sub-studies that he worked on today.
Whoa. What's it? There's a. Oh, okay. I'm not sure what it's auto advanced. Let's try. Try those. It's auto advancing. 1 second. That's strange. Slideshow. Is there some kind of transition? Duration. Oh wow. 1 second. Let me remove all the transitions we have. They're set up to, for some reason, go automatically. Yes. Try again. Yep. What is happening? On mouse. Okay, one more. One more. No. We're gonna get this. We're gonna get this. On click. Do you know what's happening?
It's transition.
It's advancing by itself after, look at this, it's set to after 0.07 seconds for all of them. Can we get rid of all that for all of them? Just uncheck it. Can you uncheck it? But it should be on mouse click, right? One more time.
Okay, try go back to the beginning. See,
Did that change all of them? No, it only changed one slide. Oh, where do you see that?
go to slide.
Oh, I see it. I see it.
Yeah, apply to all right there.
Uncheck that on mouse click.
And then hit apply
Apply.
to all.
Okay.
Try now. Okay, that's our part.
Thank you, audience.
Sorry for the delay. So, good morning, everyone. It is my privilege to present a few imaging-based sub-analysis derived from parent LO3 study. I would like to thank Dr. Kinney and Dr. Yulia for their support in making these projects possible. These studies are mainly mechanistic in nature and should be interpreted as hypothesis generating. So, my agenda is longitudinal changes following maximum lipid lowering therapy in angiography-derived physiology, radial wall strain, OCT-derived lipid to cap ratio, OCT-derived physiology and tissue composition, and physiological disease patterns. So there are several invasive and non-invasive imaging modalities available to identify high-risk coronary plaques, as seen in this table. In LO3, we used 3 imaging modalities, that is IVUS, OCT, and near-infrared spectroscopy in addition to angiography. These techniques capture most of the key features associated with high-risk plaques, and the information they provide is complementary to each other. So with IVUS, OCT, and near-infrared spectroscopy, we can get plaque burden, positive remodeling, low attenuation plaque, minimal lumen area, intraplaque hemorrhage, TCFA, lipidac, macrophage, microvasculature, also the layered plaque. So recently, there is a new technology called photon counting CCTA, which has demonstrated excellent spatial resolution up to 120 microns, approaching that of IVUS, and represents a promising technology as a complementary imaging technique to watch out in the future. So I would like to introduce few concepts followed by results of our post-hoc mechanistic studies. The first concept is angiography-derived physiology. So for angiography-derived physiology, the first step is 3D geometric reconstruction. For this, you need 2 angiographic views at least 25 degrees apart to eliminate 2D limitations like vessel, foreshortening, or overlap. Following this, the software uses these views to build a 3D model as in figure C, allowing for precise anatomical measurements beyond simple diameter stenosis. And after this, there is patient-specific flow analysis based on TIMI frame counting. Like here you can see the software tracks the contrast bolus from E1 to E9 and calculates the actual blood velocity. This baseline flow is then mathematically scaled to simulate maximal hyperemia. So you no need to give adenosine. And then we apply computational fluid dynamic equations. For example, in this case, we use Lanz-Gould equation where drop in pressure is related by this equation, FQ plus SQ square, where Q is flow, F is frictional coefficient, and S is separation coefficient or inertial turbulence. The result is a color-coded map providing a QFR value. A value less than 0.80 is called functionally significant. Finally, we get a color-coded virtual FFR pullback curve, which is very similar to the hyperemic wire-based pullback curve. With this pullback curve, we can identify the precise areas of pressure drop. Also, we can quantify and classify the disease patterns as either focal or diffuse, which I will be explaining later. So this table summarizes the currently available angiography-based FFR softwares and the studies supporting each software. Although these systems use different computational methods, all have been validated against wire-based FFR and demonstrate good diagnostic accuracy. For our post-hoc analysis, we used micro-FFR, which is based on single angiographic view and applies the Kirkiri equation as computational method. So Murray law-based QFR or micro-FFR incorporates Murray's law to determine flow distribution whereby the larger branches receive disproportionately greater blood flow following a cubic relationship with vessel diameter. We can also derive FFR using OCT images. This is called optical flow ratio or OCT-derived FFR. The OCT software reconstructs a high-resolution 3D model of the coronary artery, enabling precise assessment of lumen geometry and plaque characteristics. OFR estimates blood flow based on vessel dimensions and applies principles such as Murray law to model blood flow distribution across branches. The software then simulates hyperemic conditions and calculates pressure drop along the vessel using simplified fluid dynamic equations, as I mentioned before. And we also get a pullback curve similar to the virtual FFR pullback curve like this here. Both these softwares have been validated against wire-based FFR with good accuracy. So this slide summarizes the key randomized trials of angiography-based FFR in intermediate lesions to guide PCI. In Favor 3 China trial, which was published in 2021, QFR guided PCI reduced 1 year composite event rate from there was a event rate of 8.8% in standard angiography guided arm and 5.8% in QFR guided arm. Recently, All Rise and FAST3 were presented at ACC and simultaneously published in NEJM. Both trials showed that FFR guided PCI in intermediate coronary lesions was non-inferior to wire-based FFR. So in 2024, ESC CCS guidelines give a class 1 level B recommendation for QFR in functional assessment of coronary stenosis to guide revascularization in patients with multi-vessel disease QFR as class 1A and class 2A to be of using QFR at the end of procedure to optimize PCI. So the second concept is angiography-derived radial wall strain. So angiography-derived radial wall strain reflects radial deformation of the vessel wall driven by pulsatile pressure during different phases of cardiac cycle. The radial wall strain software tracks the diameter changes frame by frame and calculates radial wall strain using this formula, which is a relative change between maximum and minimum diameters. On the left side, we are examining the right coronary artery in different phases of cardiac cycle. Basically, the software quantifies the change in the lumen diameter in different cardiac cycles. Most of the time, the maximum changes in lumen diameter is at the throat of the lesion or at the site of minimal lumen diameter. And we get a map of radial wall strain for each frame for entire coronary segment, but usually the maximum radial wall strain is reported. For example, in this case, radial wall strain can be calculated as 1.9 minus 1.6 divided by 1.9 multiplied by 100%, which is dimensionless, and here it is 15%. So this is one case example of a 40-year-old patient who presented with non-ST elevation ACS who had culprit lesion in LCX, but at the same time he had intermediate lesion in mid RCA. So when the QFR was done, it was 0.90, so it was not interbeam. However, retrospectively, when radial wall strain was calculated, it was high, 27.7%. At 9 months follow-up, this patient developed subacute occlusion of mid RCA. So that the third concept is lipid to cap ratio. This workflow shows how to calculate lipid to cap ratio. Firstly, we acquire a OCT pullback across a lesion and between two anatomical landmarks. In the second workflow, there is a software called OCT Plus, which quantifies or characterizes the tissue at every frame into lipid, fibrous tissue, calcified plaque. It also delineates internal elastic lamina and calculates fibrous cap thickness. In the third step, lipid cap ratio is calculated per frame as lipid plaque burden divided by fibrous cap thickness. In the fourth step, using a sliding window of 5 frames, you calculate the maximum lipid cap ratio, and for the lesion, you take the maximum lipid cap ratio for statistical analysis. The AI-based OCT software has been validated in 3 international core labs, and it was trained based on artificial intelligence using 10,000 frames. So in this retrospective analysis of 124 lesions, vessels with radial wall strain more than 12%, patient who had radial wall strain more than 12% showed a higher prevalence of thin cap fibroathyroma, thinner fibrous cap thickness, larger lipidic burden, and higher lipid to cap ratio. In 604 patients with ACS who underwent OCT imaging in more than or equal to 1 non-culprit vessel, lipid cap ratio, OCT-derived FFR, minimal lumen area, and TCFA were evaluated. Patients with both a lipid cap ratio of more than 0.33 and OCT-derived FFR less than 0.8 had significantly higher risk of non-culprit vessel-related MACE at 2 years, with a hazard ratio of 42. In 484 vessels differed after FFR assessment with available radial wall strain data and CCTA, higher radial wall strain was associated with greater likelihood of having FFR less than 0.80, higher risk of having high-risk plaque features defined as plaque burden more than 70 and MLA less than 4 millimeters square, and it was associated with continued risk of target vessel failure with a hazard ratio of 1.23. The prognostic value of radial wall strain more than 14% was independent of FFR less than 0.80 and high-risk plaque features. This is the post-hoc analysis of 824 non-flow limiting vessels in favor 3 China trial. So here the blue bar represents angiographic non-significant stenosis, that is diameter stenosis less than 50%. Red bar indicates physiologically non-significant stenosis, that is QFR more than 0.80, and black bar represents QFR more than 0.80 and radial wall strain less than or equal to 12%. So in this study, we can see the event rates are consistently lower when the vessels were deferred based on both QFR and radial wall strain. So adding radial wall strain to QFR may improve the safety of deferring revascularization in non-hemodynamic significant stenosis. Building on the evidence, there is a trial which is ongoing called Favor 5 AMI randomized trial, which is testing micro-FR and radial wall strain guided strategy versus standard treatment strategy for the treatment of non-culprit lesions who undergo successful TCIF culprit artery after stemming. So in this strategy, if the patient has QFR less than 0.80 or radial wall strain more than 13%, and they have diameter stenosis more than 50%, TCI will be performed. However, if the QFR is more than 0.80 and radial wall strain is less than 13%, TCI will be deferred. In the standard treatment strategy, if the diameter stenosis is more than 70%, TCI will be performed. And if the diameter stenosis between 50 to 70%, FFR or IFR guided TCI will be performed. So the next concept is pullback pressure gradient. The concept of pullback pressure gradient was first introduced in 2019 by Carlos Cole based on motorized hyperemic wire-based FFR pullback at 1 millimeter per second. Here, the functional disease was defined as drop in FFR of more than or equal to 0.0015 per millimeter. PPG is a new metric which characterizes the disease as either focal or diffuse in a quantitative manner and objectively. It is a continuous metric, and the formula to calculate is here. Most important things are maximum PPG 20 mm. This is maximum drop of FFR in 20 millimeter of the interrogated vessel. Delta FFR is the difference between the FFR at the ostium and the distal point of measurement. Length of functional disease is length of vessel with FFR drop more than or equal to 0.0015 millimeter per millimeter. So values close to 0 depict diffuse disease, whereas values close to 1 represent focal disease. So in the first illustration, LAD has a lesion in mid segment. Second illustration, there are lesions in both proximal and mid LAD. And in the third illustration, lesion is again located in the mid LAD. So when we see the FFR pullback curves, we also see the red bars. So here the red bars indicate FFR drop of more than 0.0015 per millimeter. So in focal lesions, the FFR drop is localized to focal points. So the red bars are not diffusely distributed throughout the interrogated length. It is focally distributed. So when we use the equation, the length of functional disease in this case was 20 millimeters, and the PPG index was 0.86, which was closer to 1. So this was classified as focal disease. In diffuse CAT, we can see the red bars are throughout the vessel, meaning that FFR drop of more than 0.015 is throughout the vessel, and the drop in FFR is diffuse. So when we use the formula, the length of a vessel with functional disease was 74 millimeters. So the PPG index was 0.28. This was diffuse disease. So initial studies were based on motorized FFR hyperemic pullbacks, but now we can calculate PPG also from QFR pullback curves. This was the first study showing the feasibility of using QFR based pullback curves to calculate PPG. And these have been validated against wire based pullback curves recently. So coming to this study, this is the FITA study recently published in Neurointervention in patients with ACS undergoing TCI of culprit lesion with an important non-culprit lesion with FFR of 0.67 to 0.85 were randomized to evolocumab plus hydrostatin versus placebo plus hydrostatin. At baseline, FFR and IVAS NIRS was performed, and follow repeat FFR and IVAS NIRS was performed. So basically, there was no difference in the change in FFR and maximum LCBA4 at 12 weeks. So this is the pre-specified analysis of evaporate study, where FFR is derived from CT. This is the study design. Here, patients is 30 to 85 with triglycerides of 200 to 500, LDL between 40 to 150, and diameter stenosis in at least one coronary artery were randomized to who were on stable statin therapy were randomized to Icosa pentoethyl versus placebo, and CT was done at baseline 9 months and 18 months. So in this study, Icosa pentoethyl improved mean distal segment FFRCT at 9 and 18 months follow-up compared with placebo. In this example, we can see a patient on Icosa pentoethyl. There is a lesion in proximal RCA. FFRCT was 0.67, which improved to 0.78 and 0.79 at 9 and 18 months. Similarly, delta FFRCT, that is, delta FFRCT is pressure drop across the lesion, which was 0.23 reduced to 0.07 at follow-up. However, a patient, this is an example of patient on placebo. There is a FFRCT of 0.96 in LCX, which reduced to 0.56. There is basically progression of disease in LCX. Also exemplified by increase in delta FFRCT across the region. So coming to our so this is our methods. So our study is post-hoc analysis of 110 vessels with paired micro-FFR lesion, radial wall-strain PPG, and we had 105 OCT pullbacks which were analyzable for lipid to cap ratio. So in core lab, whenever we do longitudinal analysis, accurate co-registration is very important. So there is a matcher investigator who will select the closest angiographic projection between baseline and 6 months follow, and is matching the lesions on OCT based on anatomical landmarks at baseline and 6 months follow, and is defining the measurement sites for micro-FFR vessel as seen on the arrows that the matcher investigator is telling analyst A and analyst B, which are analyzing baseline and follow, who are blinded to the timeline, also blinded to the clinical data. So matcher investigator is basically giving anatomical landmarks between which they have to analyze the vessel and the lesion. So this is the three examples of improvement in micro-FFR vessel and radial wall strain. There was improvement in all three vessels like LAD, LCX, and RCA in both micro-FFR vessel and radial wall strain. Okay, so this is the, I'll just summarize the results. So micro-FFR improved from 0.8 to 0.89. Radial wall strain reduced from 17 to 15%. Lipid cap ratio improved from 0.2 to 0.16. Reduction in radial wall strain did not correlate with maximum LCBA. Reduction in radial wall strain did not correlate with minimum fibrous cap thickness. However, radial wall strain correlated with reduction in lipid to cap ratio. So I'll go to last slide basically. So our key mechanistic insights after adding evolocumab to maximally tolerated statins were improvements in angiography-derived coronary physiology over 26 weeks. There was modest improvement in angiography-derived micro-FFR. Radial wall strain decreased significantly. Pullback pressure gradient improved modestly. Lipid cap ratio reduced significantly. Correlated and independently predicted reduction in radial wall strain. Both focal and diffuse disease responded to maximum lipid lowering therapy equally, with diffuse lesions demonstrating a higher proportion of LCBA responders. There was modest improvement in OCT-derived physiology with significant reduction in lipid, increase in fibrous tissue, and a preferential increase in calcium tissue proportion. Improvement in OFR correlated with reduction in total atheroma volume, lipid volume, and LCBA. Thank you.
Review or almost accepted paper, Prithvi.
Go ahead and log in.
While we are setting up, I'll be introducing Dr. Narula. It's a pleasure for me to introduce Dr. Jagat Narula, who everybody knows. He was part of Sinai family, then went to UT Houston to be the dean of multiple hospitals as well as the teaching institution there. He is currently the president of World Art Federation, which is another big feather in his crown. He used to be heavily involved in JACC, JAC, as well as he's one of the MACCs. More important is, he comes from a prestigious institute in India, All India Institute of Medical Science, where he did his residency as well as his cardiology, and he has PhD from it's rare to find many people who have PhD and done all that. Then used to work in Mass General under Eugene Braunwald, and we had and Dr. Fuster there. Then under Dr. Fuster here in Mount Sinai Morningside, where he was chief of cardiology, and right now in Houston, and he was heavily involved and always working with me, guiding me with the yellow trial. And his major interest has been non-invasive imaging, and I think he'll be very happy for yellow 4 will be including a non-invasive part also. Dr. Narula, thank you for coming all the way for this symposium.
Thank you so much, Anuji, for generous introduction. It is truly a pleasure. I am here for the first time in the last 3 years since I left, and it's a privilege to be among the colleagues and mentors. And thank you very much. It has been an incredible journey. The yellow family of studies, as Dr. Kinney has called it, as when I came here in 2011, was recruited here by Dr. Fuster and Dr. Sharma at that time. The study has already started. When I joined Dr. Kinney, Dr. Moreno, and Dr. Sharma, who had conceived this wonderful study, and we have learned a lot. It has been extremely informative and enlightening, and so the most important part happened, as Dr. Kinney just talked about it in our first talk, during the Yellow 2 study, when the descriptive and the predictive combination and the correlative studies were brought in with the intracoronary imaging and the transcriptomics. The descriptive transcriptomics, where we were able to differentially demonstrate as to which were the genes which were up and down, and as Dr. Kinney had earlier said, that they related to the cholesterol synthesis, to the cellular cholesterol uptake, the efflux, as well as the inflammatory pathways. And then the predictive one, as on the right hand side you would see, that which are those genes which can predict as to who are the people who are likely going to be the responder after the maximized statin therapy, and who are not going to be the responders after statins, who would require other agents to help reduce their cholesterol or LDL cholesterol levels. The third one became even more exciting. The reason is that what came out of those transcriptomic studies here was the genes that not only indicated that we were working through the lipid metabolic pathways, inflammatory pathways, but most important was that the role of the mitochondria that got highlighted. And although we did know that the atherosclerosis does have a mitochondrial involvement, we did not know that this plays such important role in induction of atherosclerosis and then resolution of atherosclerosis. So bringing in the PCSK9, LDL reduction and beyond in atherosclerosis. The conventional narrative positions PCSK9 as a cholesterol regulator, but I would like to discuss here that PCSK9 is a triple convergence molecule that connects 3 age-dependent pathways of atherosclerosis: reduction in cumulative lipid burden, mitochondrial stress, and the clonal hematopoiesis of indeterminate potential. So I would like to prove here that this is not merely an academic reframing, but it should directly influence how we stratify our patients, choose therapies, and design clinical trials. And that's what Dr. Kinney earlier said, that that is going to be the focus of the yellow 4 in the family of yellow studies. And I'm hoping that by the end, I would like to convince you that PCSK9 inhibition is pleiotropic in the truest sense. So, when we ask as to what is the single most important powerful predictor of coronary artery disease, the answer is, of course, the age. And it is not even close. It is the big elephant in the room. Because 70% of the cardiovascular deaths occur after 65, and there is a threefold risk increase per decade after the age of 40. So, between the ages of 40 and 80, the risk of the major adverse cardiac events increases by 15-fold. So, what is it about aging that so relentlessly drives the atherosclerosis? And obviously, we would expect that the longer exposure to the risk factors captures the most important dimension here, but that is not only true, because aging drives atherosclerosis through three distinct but converging mechanisms, each with its own subcellular biology, therapeutic target, and clinical biomarkers, again, as Dr. Kinney explained in her last slide. So, if we talk about this central hypothesis, or central thesis rather, that the convergence of the three pillars, let's say that the pillar 1 is the cumulative LDL burden, that is the age times time times the concentration of LDL. It is the integral of the LDL over a lifetime. The pillar 2 is the mitochondrial stress and dysfunction, which is actually the engine that converts the lipid deposition into the plaque progression, which was so eloquently talked about by Dr. Moreno. So the mitochondrial stress and dysfunction that accumulates the mitochondrial damage, releases the fragmented mitochondrial DNA into the cytoplasm, activates the inflammasome platform, and drives the chronic sterile inflammation. And the pillar 3 is the clonal hematopoiesis, which is the age-dependent somatic mutations in hematopoietic stem cells. They produce hyperinflammatory immune cells to amplify atheroinflammation via the inflammasome pathways. Now, PCSK9 uniquely participates in all three pillars, the directly with the pillar 1 and 2, and indirectly with the pillar 3. Now, the first, when we talk about the cumulative LDL burden, which is the age times time times concentration. So, this is like, for example, if you look at the right-hand panel here and look at the graph, and at the age 40, the difference of the LDL 70 and 130 is modest, because both would have accumulated about 1200 or 1.2 grams per DL years of the total cholesterol burden. But by the age 40, the same LDL 130 has accumulated over 7,500 of the exposure, compared with only about 4,000 of the LDL at 70. That is nearly double the cumulative burden. So, if you look at the Mendelian randomization based on that data, the dashed line, which you can see here at 5 grams per DL years, that is the threshold for the major adverse cardiac events. So the 130 LDL curve crosses this threshold at the age of 55, whereas the LDL under 70 may never reach it. And a 10 milligram per DL lifelong reduction leads to about 16 to 18% fewer events. So yes, when you would add upon the statins, the PCSK9 inhibitors, it would be able to drive the likelihood of events further lower. And the best of the experiment, which is the natural experiment, in this case is the PCSK9 loss of function. For example, the mutations like Y142X, and there is a modest about 30% or 33% lower LDL-C when there is a loss of function. Now, CAD reduction in this case is disproportionately high, that you will have about 90% lower major adverse cardiac events, and this mismatch is 3 times greater benefit than the statin equivalent. So now, if you have the same statin equivalent in the mid-age, when we start these statins, if there is about 33% reduction in the LDL cholesterol level, the benefit is approximately 30% in terms of outcomes. So the same LDL lowering, wildly different outcomes. Why is it so? And the answer is the time. The loss of function carriers had lower LDL from birth, and by the age of 50 to 60, they accumulate thousands of milligrams DL years less cumulative LDL exposure than the age-matched controls. The 90% risk reduction is not disproportionate. It is exactly what the cumulative burden model predicts. Then coming to the pillar 2. Now this mitochondrial stress, which converts the lipid biology to cellular energetics and the innate immunity. So whether it is all the cardiovascular risk factors, whether it is oxidized LDL, glucose overload, cigarette smoking, or hypertension, through whatever means or whatever mediator here, whether it is the oxidized LDL or it is driving the electron transport chain overflow, or it is the cadmium in the smoke, or it is the angiotensin 2, which lead to the reactive oxygen species expression. They all risk factors, they converge on the mitochondrial damage. And as you would see in the lower panel here, that the damaged electron transport chains, they will produce significant oxidative stress. There is a fragmentation of DNA, but there are no histones, as we know, in the mitochondrial DNA. So there is no protection of the fragmentation. And then the fragmented mitochondrial DNAs, they leak through the back pores, and then as they come into the cytoplasm, they work through the sting inflammasome pathways because they are recognized as the damage associated molecular patterns there. And then another important thing which is happening is that through the Pink and Parkin pathways, which actually they label the mitochondria or the damaged mitochondria and activate the mitophagy or autophagy, and they fail during the aging. So this becomes a self-amplifying cascade, which is independent of the inciting insult. So the fragmented mitochondria increase the oxidative stress, they increase the damage, there is more mitochondrial DNA release, more inflammation, more new mitochondrial fragmentation, more inflammation. Hence, there is a chronic sterile vascular inflammation. So where does the PCSK9 enter into this pathway? So PCSK9 is a direct mitochondrial toxin. It works through distinct LDL receptor independent mechanisms. So one important thing is through the DARPA1 fission, where the PCSK9, it promotes the mitochondrial fission, all in the vascular smooth muscle cells, endothelial cells, cardiomyocytes, and it converts the mitochondria into the smaller, fragmented mitochondria with the impaired membrane potential. Then there is a complex 3, the ETC complex 3 impairment, which is through the ubiquin cytochrome C subunits, where the mitochondrial reactive oxygen bursts, they occur in the endothelial cells. And finally, there is the PINK1 Parkin pathway blockade by the PCSK9. So this is a bidirectional loop that which feeds into each other, and Dr. Kinney was talking about it as to whether it is the mitochondrial stress or inflammation. So mitochondrial stress leads to inflammation, and inflammation leads to the mitochondrial stress, leading to a vicious cycle. That PCSK9 activates the inflammasomes. The inflammasomes, they activate the IL-1 beta, and then that stimulates the PCSK9 secretion, and PCSK9 is both the cause and the product of the mitochondrial stress cycle. So then there are amplifiers and there are counter regulators here. And what exactly happens in aging is that the counter regulators they decline and the amplifiers win. And one of the other important amplifier here, which Dr. Rosenson will agree with me, is the lipoprotein A in this particular cycle. The third is the clonal hematopoiesis of indeterminate potential. And this is the paper that I'm referring to, was the paper which came from Dr. Fuster's collaboration with the Broad Institute. And as you would see here, that these are the somatic mutations in the hematopoietic stem cells, and the most important mutations being TET2, dynamite 3A, asexual 1, and the JAK2, as we commonly analyze. And their prevalence it increases with the age. It is less than 1% by the age of 40, but reaches almost 10% by the age of 70. And the cardiovascular risk, which is 2 times for the coronary artery disease and 4 times for the early myocardial infarction. So there is an exponential rise that mirrors the rise of the atherosclerosis with age. So what exactly happens is that rarely or very infrequently, this chip mutations, which are the somatic mutations, which can again happen, as Dr. Kinney was saying, because of the lifestyle, dietary patterns, smoke, and etc. There is an importance here that it would only rarely lead to the blood malignancies or the blood cell malignancies. But since these cells, if they have the mutations in the macrophages or mutations in the cells which are involved in the immune mechanisms, these cells become angry cells. They produce a lot of interleukin 1 beta, etc., and they add to the sterile inflammation. And specifically, when the mitochondrial DNA starts to come into the cytoplasm, it acts quite like the virus itself. We know that mitochondrial DNA is not ours. It is something which is parasitic in our cells. So whenever there is a damage mitochondrial DNA, it quite acts like the interferon pathways, quite like the viruses, and it causes the sterile inflammation. So chip mutant macrophages overproduce IL-1 beta and IL-6 through epigenetic de-repression of the inflammasome pathways, and that brings us to a critical convergence point here. Now, what is the critical convergence point? That the inflammasome is being activated from both sides, from the pillar 3 as well as from the pillar 2. Pillar 2 was the mitochondrial stress, pillar 3 was the chip, and they are all working through the inflammasome or the NILRIP3 pathway. And as we can see that this is a synergistic amplification, and two independent inputs are greater than the additive inflammation. And that is again important because the increase in the IL-1 beta and IL-18, they cause accelerated atherosclerosis as well as plaque instability. Now, when we look at the CANTOS trial, which was one of the very important trials that we have seen, where they have used the IL-1 beta, that the secondary analysis of the CANTOS that showed that the chip carriers, they had a greater reduction in the major adverse cardiac events as compared to the non-carriers. There was a 66% greater reduction in the carriers. And the interpretation was that the chip amplifies through IL-1 beta. Targeting IL-1 beta is most effective in chip carriers. So the chip carriers get more benefit from anti-IL-1 beta therapy, validating the inflammasome convergence model. Now, where does PCSK9 fit into this chip story? So what are the important convergence areas here? So one is that they share this inflammasome pathway, as I showed earlier. There is a very significant relationship between the circulating levels of the TET2 mutation and the PCSK9 levels. And finally, there is an oxidative stress selection, which makes PCSK9 significantly relevant. Now, can we identify the mitochondrial stress by the clinical assessment? There are multiple of the pathways which have been shown, the circulating pathways, the genomic pathways, metabolomic pathways, as well as by imaging also. But most importantly, if you want to have a small prescription here, it will be the cell-free mitochondrial DNA, GDF15, SL-carnitine profile, mitochondrial DNA copy number, and the chip screening for the 3 or 4 mutations, which could help us go to the precision cardiovascular medicine, and which will make a case for the combination therapy. Now, what would be the combination therapy here? That the PCSK9 alone leaves chip-driven inflammasome risk unaddressed. Anti-inflammasome alone anti-inflammatories alone leave the LDL burden and mitochondrial toxicity unaddressed. The TIMI data suggest there is a trend towards less PCSK9 inhibitor benefit in the chip carriers, so-called residual risk, and the CANTOS shows that the chip carriers get more benefit from the anti-IL-1 beta therapy. So together, the mechanism matched combination targeting all age-dependent pillars could be of help. Now, if we look at the CERT trial, where the methotrexate was given, it failed possibly because it did not target the mitochondrial inflammasome axis. On the other hand, the improved outcomes with the GLP therapies and the SGLT2I inhibitors that are considered to be effective interventions on pillar 2. So to conclude, atherosclerosis obviously is and fundamentally is a disease of aging. It is driven by 3 age-dependent mechanisms. The cumulative LDL burden, mitochondrial stress, and CHIP converge to produce vascular inflammation. PCSK9 is unique. It participates in all 3 mechanisms, either directly or indirectly. PCSK9 inhibitors provide multi-mechanism protection far beyond LDL reduction, and the combination therapies may someday become optimal, specifically if we find more benign anti-inflammatory drugs which are effective against the CHIP mutations. And the biomarker panels and the CHIP screening can enable the precision medicine. Now, the story will not be complete unless I talk a little bit about the PCSK9 evolution. And these are the last 4 or 5 slides here. So PCSK9 has lived too many lives and is now killing us because it is doing exactly what it was designed to do. The timeline anchors the 500 million year span. The inflection point arrived about 150 years ago when the diet explosion fundamentally changed the content. Let us trace it from the beginning, act by act. It did not all start in the liver. So, PCSK9 was a neural sculptor. It was first described as the 9th proprotein convertase as an apoptotic agent for sculpting the cerebellar granule neurons. Nothing in this origin foretold us about the career in cardiovascular disease. The PCSK9 is a protease, obviously, that cleaves itself first when it is being biosynthesized, but that prodromain stays wedged in its catalytic cleft like a sword in scabbard. In its current avatar, it binds the LDL receptor, rides with it to the lysosome, and ensures destruction, quite like a molecular bouncer that grabs you by the collar and walks you to the exit. The role best understood in the families with gain of function and familial hypercholesterolemia. The loss of function carriers who are healthy, fertile, and cognitively normal tell us that the brain function now has found other ways to manage without the PCSK9 help. So evolution did not build PCSK9 for cholesterol. It co-opted a brain protein and gave it a second career. So, Act 2, PCSK9 in a cholesterol scarce world. Why would evolution build a molecule that would raise cholesterol and destroy us? Because in vertebrate history, cholesterol was not a threat. It was a precious commodity. Ancestral LDL ranged from 40 to 50 milligram per dl, and our children are born with 25 to 30 milligram LDL. All animals are LDL 25 to 30. The rise happened postnatally, driven by diet and hence the PCSK9 activity. Then why did PCSK9 evolve differently? The liver expresses the most LDL receptors of any organ. Without a break, the liver would have hoovered up all circulating LDL and would have starved other organs. So PCSK9 degrades hepatic LDL receptors, keeps cholesterol in circulation, redistributes it to the peripheral organs, quite like the adrenals and the other organs. And the PCSK9, hence, is not a villain. It's a traffic cop. preventing the liver from monopolizing a scarce resource. So every guideline that calls LDL of 100 optimal is using a reference range defined by a population at a greater risk of dying from vascular disease. The physiologically normal LDL for Homo sapiens is 50 or below. So PCSK9 evolved as a cholesterol sparing mechanism in a cholesterol scarce world. Humans are the only adult mammal with a mean LDL of more than 80 milligram per deciliter, and which is absolutely, absolutely, absolutely not acceptable. Act 3, immune warrior and evolutionary divergence. Now, this is an interesting story here. So part 1 of the story here is that LDL receptors also help hepatic clearance of pathogen lipids, quite like the lipopolysaccharides in the gram-negative bacteria and lipoticoic acid in the gram-positive bacteria. Low PCSK9, there is a faster pathogen clearance because there are more LDL receptors, but they allow an insufficient immune alarm. In environments with the high infectious disease burden, quite like in Africa and other developing countries, having some PCSK9 helps innate immune response. So the low loss of function frequency in the African populations represents an equilibrium between the cardiovascular disease and the immune benefit. So it is playing a role what it was expected to play. Part 2 of the story here is that the mammalian PCSK9 tree reveals a dramatic split in its evolutionary fate. Primates, rodents, rabbits, they show universal PCSK9 conservation, zero loss. Their diet is vegetarian diet. So there is a cholesterol scarce. They need PCSK9 to spare it for other organs. Carnivores, for example, the bats, whales, they show multiple pseudo-genization and losses. Diet is cholesterol rich. PCSK9 was unnecessary and potentially harmful. So they lost it over the evolution. About 40 million years ago, bats lost PCSK9. Hence, PCSK9 was preserved in our ancestors who could not afford to waste and abandoned by carnivores because they could not afford to keep cholesterol. So we could not waste it, they could not keep it. PCSK9 also, and I don't want to get into it, degrades the major histocompatibility class 1 antigens on tumor cells, so it actually prevents. So PCSK9 causes the metastasis also, which can be prevented, and it could be the significant pleiotropic effect. So PCSK9 is a cholesterol guardian. It's an immune calibrator. It's an MHC1 regulator. The roles that explain why primates guarded it and carnivores discarded it. Let's come to the Act 3. And Act 3 is the nature's ongoing experiment, loss of function versus gain of function. Loss of function, 33% less LDL, 90% improved risk in coronary artery disease. Gain of function, 100% increase in LDL, 300% increase in the MACE risk. So the Act 4, and that is coming to an end now, that is the modern betrayal, which is the diet hijacks PCSK9. And Dr. Kinney showed a beautiful liver diagram where she was showing it going up from glucose into the cholesterol development when she was showing the cholesterol synthesis axis. The modern diet actively amplifies PCSK9 expression through pathways our ancestors never engaged in. Right? They never ate donuts. They never ate the sugar-laced stuff that we are used to. And we start feeding our children the sugar-laced stuff right from the beginning. Dr. Fuster's experiments with the children, I think they are probably the most to-the-point experiments. So controlled diet, the baseline PCSK9 levels. High-fat diet, there is no PCSK9 change. So we blame the high fat. But fat doesn't change PCSK9. High sugar or carbohydrate diet, there is approximately 28 to 93% increase within a short term. Within a week's time, you feed the child a juice for one full week diet, and there will be more than 90% increase in the PCSK9 levels via the SREBP1C activation, a pathway which is quite different than SREBP2 cholesterol sensing pathway. The sugar therefore hijacks a fat making program, that is the SREBP pathway, that program to upregulate a cholesterol retention molecule. Hyperinsulinemia independently upregulates hepatic PCSK9 and creates a vicious cycle of sugar, insulin resistance, hyperinsulinemia, more PCSK9, fewer LDL receptors, higher LDL. And the obesity also increases. PCSK9 correlates with insulin and the C-reactive protein as well as the triglycerides. So it is sugar, not the fat. Our ancestors ate wild fruit, seasonal fruits, fibrous, low fructose. Today, 60 plus pounds of the added sugar per year that we consume. The diet does not just provide excess cholesterol, it actively raises the dam higher. And the last act here is the Act 5, which is the epigenetic entrenchment. Now, what is epigenetic entrenchment? It is a very interesting concept that the chronic metabolic stress modifies acetylation and methylation histone marks at the PCSK9 promoter. The elevated PCSK9 expression becomes structurally encoded in the chromatin. Even if you fix the diet after that, you have gotten the PCSK9. After that, do whatever you want to do. Even you fix your diet, the epigenetic marks persist. Decades of poor diet produces durable PCSK9 overexpression. The dam conserves water during drought. The flood raises the dam. Epigenetics welds the floodgates shut. So, to conclude here, the reckoning. From sculptor to saboteur to target. So 500 million years ago, it was a neural sculptor. 300 million years ago, it became a cholesterol conservator. 100 million years ago, became an immune calibrator when the infectious diseases started. 150 years ago, it became a dietary hostage. And now it is epigenetically entrenched in us. So 18 million cardiovascular deaths a year, 88% MACE reduction with loss of function, more than 90% metastasis reduction with the PCSK9 dual, 9 and 7 dual silencing, and 93% PCSK9 increase from sugar alone. What do we conclude? And that's the provocation. The provocation is, it is not a disease of molecular malfunction. It's a disease of evolutionary anachronism. Dangerous biological programs do not represent malfunction, but perfect function in a wrong context. PCSK9 inhibition is not correcting an error. It is updating a 500 million year program for world that its architects never imagined. So now we can do just in a syringe what natural selection would have taken millennia and what bats did in 40 million years. Thank you.
Thank you, Dr. Narula, for the. We went back to like a natural history. Understanding the how from cholesterol, PCSK9, what was happening. Good. So we can have the panel come up here, which includes Dr. Fuster, Dr. Greg Stone, Dr. Narula, Moreno, Dr. Sharma. Huh? Come. Everybody still be seated. Yeah. Okay, Dr. Rosenson, come. I think we have enough. I see Dr. Fuster has written down lot of notes already.
No.
Instead
Well-
of me asking the question, I think Dr. Fuster, if you can just give us a brief of what you learned from this entire session.
No, first of all, very motivating and inspirational presentations, all of them, very interesting. We are short in time, so give me just 2 minutes.
Yes.
And I have 3 comments. The first is that in the presentations that you have, you need to have a central figure, a liver, a vascular wall, and a bone marrow. And then you go into step by step what you are talking about. Otherwise, it's very difficult for the audience to capture what step are you talking about. This is my first comment. My second is that, and I will be happy to collaborate with you if you wish, is a new technology which is positron emission tomography of the bone marrow. That's where the whole macrophage cooks, is the bone marrow, as you know. And what we have found is that when there is excess of cholesterol in the vessel wall, the bone marrow reacts with tremendous macrophage outflow. But the macrophages cannot do the job because it's too much cholesterol. They commit suicide, apoptosis. And tissue factor and metalloproteinases are released, and this to me is the key of plaque rupture. The other issue that was mentioned is the issue of risk factors. They are affecting the bone marrow very directly. And this is a pro-inflammatory effect. The metabolic syndrome and actually lack of exercise. What I'm trying to emphasize is that the bone marrow is critical. And when Dr. Narula talks about different aspects of the macrophage, really is in the bone marrow as well as in the circulation close to the vessel wall, where the mitochondria are absolutely critical. My final point is what this means to the patient. And that's, I don't know the answer, except that to me, we are in a world of consumption versus everything that was presented, in particular the last talk of Dr. Narula. And that is, what can we do about it? And to me, is education. And I stop here.
Great summary by Dr. We'll have Greg Stone.
Well, thanks. I don't have as erudite summary comments, but I enjoyed the symposium very much. I think, it was fantastic listening to Jagat's last talk about the published in Lancet Hypothesis about how PCSK9 has evolved and how evolution and changes in diet and biology and other has led to a co-opting of a function of what was normally a normal regulatory enzyme, and how it has changed so much, and the fact that we can then modify it with a syringe. I like that very comment, and change, bypass what would take 10 to 100 million years. And I think that's the status that we're at. I was also impressed when I see the maps of the liver that Dr. Kinney shows. We've seen all sorts of pathways like that. There are so many interacting pathways. And a very common statement is that nature overcomes. And sometimes nature overcomes our best efforts to try to interdict in one pathway or the other. We see in CANTOS when we go too far upstream with IL-1 inhibition, what happens, right? If we try to take too big a bite at the apple, then we have untoward consequences on the immune system. So maybe IL-6 will get it right. I think that we didn't talk enough today about Lp(a), which I think is probably very important in vulnerable plaque formation. So you have basically atheroma development, you then have focal vulnerable plaque formation, and then you have actors that lead to progression and rupture. And within those macroscopic concepts, each of them have pathways that are thousandfold intricate in terms of genomics, proteomics, transcriptomics, and what leads to moving down the next step. And I think through the yellow studies, now bringing it back, we're starting to be able to measure these things. We're starting to be able to see them in patients. The last comment I'll make is that my probably favorite image of the whole day, I was telling Pedro, is that one case where you reduce the LDL from 71 to 7, and absolutely nothing happens to the quote most important vulnerable plaque characteristics. So there is so much we don't understand yet, and to be able to identify the non-responders, I think we're not there yet. To be able to identify which patients are going to respond to different kinds of agents. There's another initiative called the Centis that Dr. Fuster knows well about that's trying to be able to identify those individual predictors in individual patients, but we're a long way away.
So, we started a question about a patient asking us. So I have my good friend, Dr. Sandy Friedman, who always comes to control room with his interesting questions. So when I asked him, be in the panel, he said, I said, you just tell us when you see the patient and what's your knowledge and help us understand, because these are clinical cardiologists. Many of the clinical cardiologists are writer, and thank you for all of you for agreeing to allow your patients to be part of the various studies that we are doing. So give us your insight.
My insight was the first thing I said to Dr. Fuster was, I don't know what the hell I'm doing here. My second insight is that I'm very fond of Dr. Kenny's jewels, and I'm always telling her that, so maybe that had something to do with it. And finally, it's a big mistake to ever ask her if they're real or not. I can tell you that. So moving on. I kind of disagree. I don't think there are non-responders. I think it sounds like a conceited thing to say, but I think the door has been slammed on this problem. In 1987, statins first came out, and those of us started to using it. And high-risk people, let's say numbers needed to treat of around 35 who were getting in trouble. In those days, it was vascular disease all over the place. People were getting aneurysms. Everybody had angina. And it was like dramatic. In a matter of years, where a few of us are looking at one another and saying, what the hell is going on here? I mean, nobody's getting sick anymore. Then in around 2000, St. Francis came up with the calcium score, and they had a computer-derived number, which you all know, which showed risk not for obstructive disease, but for actual events. And that when they gave atorvastatin to patients, again, the events kind of fell off the wall. So a lot of us started using calcium scores. It was controversial in the beginning. And now in the guidelines in 2026, I think they're really hyping them. But they're hyping them for moderate risk people, like 5%. I did them on everybody who I thought had a shot at having calcium. And it was amazing what you can learn. One is that people with tons of risks can have zero calcium. People with no risks can have a ton of calcium. And then there's everything in between. So I think they just ask it for moderate risk people because, you're almost like a public health person if you're making guidelines. And a few states are now asking insurance companies to pay for these imaging tests. Medicare doesn't, Medicaid doesn't. And so I think people have to be careful when they start talking about when people should have these tests and when they shouldn't. But, I can do whatever I want. I'm a private practice. I don't care. So I ordered these tests. And it was very interesting. One thing, for example, you found things that kind of gave, and you could use biomarkers and all this stuff together in a loose algorithm to treat people, I believe. So one of the interesting things, you talk about LPA, and LPA is like the boogeyman. It is an independent risk factor. There are all these soft things that it does that are bad. But, when you do calcium scores and LPAs, you find people with very high LPAs and zero calcium scores. And you wonder how that happens. So what I would do is in a person with high LPA, particularly when they're younger, I would take the LDL and I would bury it, kind of doing an end run route, even though the LPA is an independent risk factor for all sorts of reasons. And I found in preparing for this that there have been a lot of studies that demonstrated that the LPA has the most negative impact when the LDL is high and the LPA is high. Well, when the LDL gets extremely low, the impact of the LPA is mitigated quite a bit. So it kind of justified kind of what a lot of us were doing all the time, just treating the hell out of LDL. And, and I question when they do drug trials, if they're really going to, if they're going to test the validity of LPA lowering agents when the LDL has already been lowered. I wonder if that's going to happen or not. Then I fell in love with small particle numbers, small particle LDL. And I realized that when the ApoB was within range, you could still have a ton of small particles that were elevated. So I used that as a target with no evidence at all. And I found that people ended up with LDLs of 40 treating the small particle number. So what was I doing? I don't know. But the fact is that the numbers needed to treat to take an LDL of 120 down to 70, let's say, to make a beneficial effect. We know that. I don't think we know the numbers needed to treat to take when you take an LDL and drive it down to 40, let's say, how much of an extra difference that makes. But I do it. But the fact is, having said all of this mishmash, and I'll get out of here in a second, the fact is that I don't remember in, let's say, the 20, 30 years that I've been doing this kind of thing, if I had an ST elevation MI or a ruptured plaque in my practice, using a very simple approach. And you say, well, he's blowing smoke. But when you think about it, when you go to the cath conferences and they're trying to find ST elevation MIs in our neighborhood, they can't find them. They got to go out to Elmhurst to harvest them to bring them in. So it seems to me that we are actually slamming the door using very simple approaches already. And so there are two missing links. One missing link is that the problems you get is that people get old and they become walking concrete vessels, and they have wide pulse pressures. And then we're told if you treat the blood pressure to 120, the patients will be okay. But they won't be. They don't feel good. And so you realize that blood pressure management is this big compromise, and you got to juggle it. And so that whole problem of keeping vessels pliable is kind of a separate but perhaps related issue. And then small vessel disease and all the types of things that Dr. Fuster has been teaching us about. So, I mean, I guess that's about it. This whole talk was amazing, but from my point of view, it kind of justifies in an unbelievably eloquent way the very simple things that many of us have been doing all along. And I think the major problem is what Dr. Fuster says is communication, is finding healthcare practitioners that will actually, develop personal relationships so you can use all of these things. And I think the problem is that there aren't enough. And the kinds of things that, as I remember, Dr. Fuster does, he kind of gets groups of people together who must be inspired and young and motivating, to get on a larger scale these kinds of things done. But I think that's the problem, is the healthcare delivery more than the tools that we actually have to deal with. And that's what I think.
Great. Now, why you don't see stating? Huh?
I'm glad you invited me.
Yes, 100%. Because we need some people to, say the truth. And one of them is, you said you don't see ST elevation MI because you're taking care of an affluent area. You're in the mid-upper east Manhattan, and you're saying we have to go to Elmhurst because it's an area of neglect. I think that's what Dr. Sharma always has been saying, is ST elevation MI is a disease of neglect, which is all we are talking about, right? Yes. Mm.
If that small particle thing, I have patients who have small particle LDLs that are less than 90 nanomoles, whatever, per deciliter, basically undetectable. They have the longevity syndrome. They never get sick. They never get atherosclerosis. In fact, they never get anything. So I'm just saying that's partly supportive for that particular technology.
Longevity is another symposium. I love that subject. So going back to, I think, small particles, we can go to Dr. Rosenson, because this is one study, Dr. Rosenson, we work together, and you can talk to us about, small particles. And this is a sub-study of statin and LPA. Yes.
Thank you. Thank you for allowing me to join the panel. And first, I'd like to say it's just a beautiful example of translational work and how the new technologies have allowed us to enhance our understanding, and coupled with the imaging modalities, it's really a wonderful time for science, and you've really led the effort here in the Yellow study. So big compliment. There's a lot of complexity of disease, and a lot of competing pathways. And the best way we can help patients with a personalized approach is trying to understand these pathways and integrate them. As an example, that you showed the work from Ken Gurwitz, our advanced preventive cardiology fellow that you allowed to access and work with your team on the yellow study. And, we're aware that statins can increase LPA levels about 3 to 5%. Some people get a much bigger increase in LPA levels. And the question is, what's the net effect on the vessel wall? And what we showed in this publication in Cardiovascular Drugs and Therapy is that the benefit of the statins on fibrous cap thickness was maintained despite, the increase in lipoprotein A, which was actually quite large, in this study. Well, let's talk a little bit about biomarkers and how biomarkers are useful, as we can say, for guidelines, public health recommendations, because we can't do these very detailed analyses in all individuals. And we, discovered that there's a link between LPA, inflammation in terms of proteomics, transcriptomics, and it's actually functional, leading to more blood clots. And tissue factor really underlies that process. In the work of Dr. Narula, Dr. Fuster, talking about the tissue factor pathway, is very important. In a paper that we just published about 3 weeks ago in the Journal of Clinical Investigation, we looked at individuals in Cardia and UK Biobank who had an LPA proteomic score that was high, enriched in inflammatory proteins, low in tissue factor pathway inhibitor, versus those without. It actually predicted new plaque and also predicted cardiovascular events at 20 years. And so it's this interplay between lipoproteins and certain individuals who have these proteomic profiles leading to more atherosclerosis and more events, and trying to tease that out, I think, is very important to try and target these therapies, because our patients can't be on everything. We need to better understand those pathways. And I think that's very exciting. With regards to the comment about the ongoing clinical trials of LPA and LDL, there are, large segments of individuals, particularly in the United States and Western Europe, who are on PCSK9 inhibitors and then get randomized to a selective LPA lowering drug versus placebo. So we'll be able to look at the interaction between LDL and LPA. LPA is one of multiple ApoB-containing lipoproteins circulating in our vessel walls. In our bloodstream interacting with the vessel walls, but LPA is about 6 times more atherogenic than an LDL particle. So if you markedly reduce the LDL particles, what is the effect of LPA in those individuals versus those who had higher LDL particle concentration and higher LPA levels? The clinical trials will be able to give us some guidance in that direction. So it's a really exciting time, for translational research. And again, big compliments.
Thank you. Anybody else in the panel want to say anything from the audience? I don't have any questions from the...
Yeah, I want to say something.
Mm.
So what did we learn? What do we do with our patients? Dr. Fuster, last comment. We are leaders in healthcare, from the MA to Dr. Narula and Dr. Fuster. But first, we have to understand that we are responsible for ourselves. That's a big lack. You spend your life enjoying and having this, working very hard so you can do this and the big restaurants and the, Daniel Boulud and all this. But at the end of the day, if you become, like Dr. Sharma did actually, conscious of your own, then you can be a leader. Changing the world starts with changing ourselves. And that's probably the only message that I got, because of beautiful, actually fantastic meeting. We went from the pessimistic data of after the pandemic, how heart disease is back up, to the super optimistic Sandy Friedman, excellent doctor. But in the meantime, what do we have? We have ourselves. And that's probably my only message, which is not medical, it's kind of philosophical. Thank you.
No, this slide. Okay, go back to this slide. So this was a work Dr. Rosenson, hey, go back, was talking about.
It should have
Come back. So Dr. Rosenson and his fellow who actually has moved on, Gurvitz, she's the one who did this work. This was from LP little a that we measured in a yellow 2 study. So I know everybody talks about the way I reason we put it here, and I'm going to show one more slide. The statin increases LP little a, everybody knows that. And I showed the picture, LP little a, it's a little protein that is sitting on the LDL, and that particular part, it is highly atherogenic. Why it's atherogenic, we don't know, but you saw that it becomes, but what we saw is that high LP little a, people who had high LP little a had the largest change in the fibrous cap. Don't you think that's interesting? And this paper was, presented just this year in cardiovascular drugs, and she actually presented in a couple of the meetings. The other one, go back, there was one other from Hoggins and other trial where it's just very interesting concept. It's great.
Whenever we enter presentation mode,
Yeah. Go. Yes. Go back. Go to the extra slides.
It's thinner, but the statins, which increase the fibrous cap thickness, offset the increase in the LPA on the fibrous cap. So, the statins, are really important for plaque stabilization. Yeah.
Okay, I think there's more LP little a and PCSK9 that will be our future study. So I think what we decided, this was the first of our meeting, and every quarter we will have similar meetings related to the various work that we do in Mount Sinai. What we say, there are various leaders, we say, and we will continue this meeting. The next one, we will work on calcium nodule, which will be both part of yellow trial as well as how intervention will take care of the nodules. Thank you for everybody being here and being part of this first.
I just want to say, not about the subject, is the devotion, the time, efforts it takes. This all yellow trials was developed, brainchild of Anu, and all the funding, whatever $5-10 million and going further, it all she got it at her own merit. Of course, institution of big support of all the leaders here, but on her. And imagine these patients, you do that imaging testing, then you're bringing them to the, whether 4 weeks, 6 weeks, or 2 months later, and doing again imaging, and with a 95% compliance that patients are coming back. Because such a well-oiled system she has developed, and that is the real hallmark of the yellow trial. So very simple. You do whatever we learn ourselves and to our patient, but just to be dedicated and create a niche for yourself. But it's the persistence which speaks for it. And that's a tremendous, thank you. Thank you. Very much. I think we are late, but all fantastic.
This was the most amazing lecture. Good job, too.
We are not part of the bone marrow yet. Yeah. We have to think about bone marrow. Yeah.